Good afternoon, everyone. My name is Vincent Cavalieri, and I'll be moderating today's session on utilizing antipsychotic therapeutic drug monitoring. Our presenter today is Dr. Megan Ehret. She's a professor and co-director of the mental health program at the University of Maryland School of Pharmacy, with a practice site at the University of Maryland Midtown campus. Additionally, she has the privilege of working with the State of Maryland Medicaid program in evaluating antipsychotic use in the state, including development of clinical criteria for antipsychotics and authorizing and reviewing psychotropic use in the pediatric population. So without further ado, Dr. Megan Ehret.
Thank you, Vinny, so much for that lovely introduction. I'm so excited to be with all of you again today as we wrap out this three-part series on clozapine TDM. So if you were here over the summer, there were 2 additional webinars, and if you need those, we will provide them at a later date. But that was a nice opportunity to get some background on TDM. And so today we're going to focus a lot on the clinical opportunities for it. So we'll briefly review some of the need for TDM, how we at the University of Maryland made the case for rapid clozapine level monitoring. And this is very important in thinking about how do I get my hospital or administration to buy into needing this rapid level. We will discuss the benefits of using the rapid clozapine results. And I brought today some real life examples of things that have happened in our institution so you could see some of the benefits and some of the places where benefits weren't utilized. We're going to talk about managing the change to in-house testing and what this might look like in educating our providers. We'll talk about some barriers and then really some best practices around using these levels as you switch potentially from an send-out method to that in-house method. So we have a lot to cover today in our hour together. Our institution at the University of Maryland, we started with clozapine as a send-out. When I first started there, all of our clozapine was being sent out. We looked at all of the data to look at how long it was taking on average for those test results to come back in. So doing the send out for the LCMS took about 88 hours from drawing time to results to the physician. And in December of 2022, our Christmas miracle, we had the implementation of clozapine immunoassay in-house. And when we went in-house within the first year, our time to results dropped to 4.2 hours. So from time to draw to results to the chart took about 4 hours. So a significant decrease in time. Why would we guess on a level when we can easily obtain it and have some objective information to determine a lot of different components of care with clozapine? This happens to be one of my most favorite slides when thinking about factors that can change drug metabolism. There are so many factors to consider. I think most of us have spent a good deal of time talking about a lot of these different things. Pharmacogenomics, thinking about pregnancy, thinking about smoking tobacco, marijuana, GI function, renal, liver, so many different things that can affect how drugs are metabolized. And when we are interviewing patients, talking with them, trying to determine medication histories, it's very hard to remember all of these different things and inquire about them, but it's also hard for a patient to recall all of these things or be aware that even they've done some of these things or been exposed to various things. So a lot goes into thinking about how the drug is metabolized, and ultimately then the best way to measure that is really a concentration. It's the simplest, easiest way to verify they've taken the drug, how much of the drug potentially they've taken, and having some idea of where they are on that reference range in comparison to just making educated guesses. Now, as I said, sometimes the levels can help us sort of determine maybe where the patient is, but it is important to keep in mind that based on a daily dose, we could see a wide range of therapeutic levels. And so you can see here in this study by Yada and colleagues, the daily clozapine dosage ranging from 100 to 600 milligrams a day in a population of patients had a host of different plasma concentrations for clozapine. Our standard reference range here highlighted in green. This is where we begin to see that therapeutic efficacy for clozapine. This is typically where we will look to have a patient get to, but we can see that some patients will respond to lower doses. Some are going to require higher concentrations, and some may even require above the 1,000 nanograms per milliliter, which is typically what we think of as our upper limit for clozapine. So we may have some patients, and it's relatively few, that may hover above this. But very important to think across the board. It's so much easier if you have a level to understand where a patient is than just a dose of a medication, because we don't know how it's being metabolized in that particular patient. So a very important point to note that concentrations are very dependent in each individual patient. So measuring it is going to be the best way to be accurate around that. Many times we think that measuring blood levels is the most accurate way for assessing adherence, and I would 100% agree with that. Lots of times we just ask the patient, how many times have you missed your medication in the last week? We do pill counts. A lot of that leaves room for bias and error. Patients may not be as forthcoming when they miss medications. Pill counts can be adjusted. Patients could dump them out before they come, make sure there's the right number left in there. Lots of ways to influence bias on that. When looking at clinician assessments of medication status in the ER, and I'm going to show you one of our examples today, 42 of 97 patients were incorrectly assessed. And I think to Jonathan Meyer when I think about adherence, because he always says, oh, my patients are always adherents. It's never my patients. And I think a lot of providers always think, yes, my patients take their medications. But greater than 50% of the time, our assessment of their adherence status is going to be incorrect. And with clozapine, we don't have a lot of room for that type of error. Additionally, our clinical assessments of patients can also present challenges. So one, we know patient-reported medication status is unreliable, especially in the ER when people are in crisis or emergency. This can really be unreliable. Many times, even pharmacy data may be unreliable because you don't know if the patient's actually taken it. You don't know when the last time they took it. So it can be really unreliable. The dose of the medication isn't predictive of the serum concentration. We just saw that in the study by Yada and colleagues that the 600 milligram dose, there was a wide range of concentrations. So just knowing the dose may not be helpful. We do know that serum concentration is useful for predicting adverse effects. The higher the serum concentration, the more likely of side effects. So this would give us indications if a patient's experiencing that. We can use it to predict efficacy as well. We do have an established range, knowing that each patient is different. But keeping in mind that whole circle of things that affect drug metabolism, potential interactions with medications, with other outside factors, and infections can all change serum concentrations. And so there's a lot that would have to go in to evaluating these concentrations as well. So it's very important that we're not just using our clinical assessment, but we're using all of our objective data to help evaluate patients. So let's jump into a little bit of using the tool. And I want to show you some case reports today from our hospital about some of the things that we've seen and how we as a group can think about practices to inform our decisions. So case one, let's start in the emergency room. If we have a 19-year-old male with a history of schizophrenia, presents to the ER with complaints of auditory hallucinations. A lot of the paranoia that the patient complains about is surrounding COVID and some of the paranoia surrounding COVID. The patient is currently enrolled in a partial hospital program at our institution. The home medications in the EHR include paliperidone palmitate 156 monthly and clozapine 300 milligrams at bedtime. So 2 antipsychotics, enrolled in the PHP, but appears to have some increase in symptomatology, which has brought him to the ER. So on January 4th, the patient presents to the ER, and this is where they have the hallucinations and paranoia. The provider checks the EHR, but is really unsure of the adherence with the clozapine. Sees that the patient is on it, but can't get a good read on the patient about adherence status. Sees the patient's enrolled in PHP and has a little bit of comfort with that, knowing that the patient will have follow-up immediately the next day because the patient should be going to the partial hospital program. The emergency department provides the patient with some as-needed medications to help with the symptomatology they're experiencing, and the patient approves in the ER and is discharged from the ER with the intention that the patient will present at the PHP tomorrow. So as I look at this study, I thought back a little bit and thought, wow, probably, in an ER, and this is during COVID, keep in mind, right around the COVID era that this patient presented, probably seemed maybe that this might be what happens in an ER. We're going to triage the patient, see that there's some follow-up, and then get the patient to that follow-up and determine that the patient doesn't need to be admitted to the ER. Well, 2 days later, the patient fails to show up to the partial program and is brought to the ER. This time, the clozapine level is drawn, and we determine that it's less than 68 nanograms per milliliter. At this point, then, the patient is admitted, and clozapine is reinitiated at the much lower dose because now we don't know when the last time the clozapine dose was administered to the patient. So I went back to think, wow, if I had been here on the 4th, or if someone had been here on the 4th, perhaps we could have recommended that a clozapine level be drawn. And had we had the ability to have that rapid clozapine level on the 4th, we could have made a decision about adherence there and determined if it was low, as it was on the 6th, maybe the patient should have been admitted and retitrated then, instead of waiting 2 more days for the patient to be brought to the ER again. So that seems that we had a missed opportunity here on the 4th. And it may have been not multiple factors that led to that, but definitely a missed opportunity on getting that level on the 4th so that we didn't have the patient potentially suffer for 2 days and fall out of care and need to utilize ER services again. The patient was readmitted over the course of the next 2 weeks. The clozapine levels redrawn. The patient's doing well at 232 nanograms per milliliter. So definitely adherent on that inpatient unit more than outpatient. But I wanted to sort of demonstrate even with the level, and this was promptly probably right after our levels became rapid and we hadn't had the opportunity to get into all of the ERs and do a lot of that education to know that these levels were available for a rapid draw. So the provider may have considered sending a level, but it would have been several days to get back. So maybe not as helpful in the time. But now thinking, wow, I can have this back in 4 hours. That might be worth having the patient hang in the ER that long just so that we can determine if the patient needs to be admitted or if we need to retitrate clozapine at that time. So we needed to make the case to our administration and hospital for switching from an outpatient send out to an inpatient house. And so thinking about appropriate justification, I know all of us need to justify most of what we do every day. So we started with the thought process that clozapine plasma levels can improve patient care. We're getting results within hours. And just based on that case alone, case number 1, it was vital to improve patient management. We were easily able to determine very quickly in that emergency setting that the patient was not taking their clozapine, and it provided us some insight into needing to retitrate the medication versus perhaps increasing the dose. So it really helped us with that questionable medication adherence. It also can help when other variations affect the medication plasma levels as patients transition in and out of care. Tobacco smoking alters levels, and so this really can help determine if a patient is having a drop in levels because of smoking, or if they've been inpatient and levels are higher. If our patients aren't responding as we expect them to, I'm going to show a little bit of case later where perhaps maybe we have patients with very high levels or very low levels. They're not responding as we would expect with a particular dose. So we may need to evaluate a rapid level to make a determination. In our experience, most of LCMS results are not fast enough. In our hospital, it's taking 88 hours. So we're beyond 3 days. And this just isn't helpful when you have patients where you're trying to determine immediate adherence, because we know we may have to retitrate the medication. And the side effects and risks are severe if we restart at too high of a level. We do know that LCMS results tend to be very lab dependent and can vary over time. So depending on the personnel that's running them, perhaps the time of the day or time of the year, those lab levels can be very dependent on that lab and can change over the course of time just based on the lab. So they may not be consistent. And it's important that we have consistent levels on patients so that we're aware of where they are and where they fall. And there is an FDA cleared laboratory clozapine assessment available, and it's highly reproducible. There's a lot of great evidence to show how reproducible it is. And it's a very easy use in your lab. And I'm going to talk a little bit about how we talk to our lab directors as well, but very easy to get done. We needed to talk to our psychiatrists and our prescribing team, talk about workflow. So now if we're getting levels back within hours instead of days, what might this do to our workflow on clozapine? How might we change some of our outpatient visits? So would we consider having patients get blood drawn day before, or get their blood drawn morning of, and then having an appointment in the afternoon so that we actually have the results readily available to make real-time decisions? Thinking about having patients come in the morning, get their blood drawn. Maybe there's a group that they attend, and then they have appointments after. So there's a lot of workflow considerations. The impact on patients is great. Patients like to be engaged, like to know where they stand with their medication levels, and it helps them understand their treatment. And so we have an opportunity to make a big impact. Also an opportunity in making those real-time decisions to potentially avert hospitalizations or unnecessary phone calls and things of that sort by being able to make real-time decisions. Lots of scenarios that we can educate our psychiatrists on about when clozapine blood levels would be helpful. We've spent a lot of time talking about all of the emergency visits at appointments when you might be out on the ACT teams and just trying to get adherence concerns. There's a lot of places where this can be used. And then we spent time talking about interpretation of results with our teams. There is some bit of difference that we're going to just talk about briefly with metabolic ratios and turnaround times that change the interpretations of the results. And that rapid level makes it much quicker to make decisions over the course of time. We needed to talk about our administration. So we needed to present a plan to the administration and talked about the clinical necessity of this test, both inpatients and outpatients, and really used the risk of not testing or not measuring as a baseline, and saying if we don't measure, we are making guesses on where the patient is. And there have been case reports, I know of at least one, that suggested, a patient came in, was restarted on their clozapine at a very high dose because that's what they were on outpatient. The patient had been non-adherent, and the patient ended up in a critical state due to the potential clozapine overdose they received because they were restarted way too high. So there is a necessity for inpatients and outpatients, and it's very risky not to measure. The impact of the results on clinical decision making, this can be very quick. We could have saved ourselves another ER visit for our patient number 1 if we had gotten that level on the first day and realized it may have been low. We might have been able to admit then and get that clozapine retitrated sooner rather than those additional visits outpatient. Cost of incorrect decisions, either withholding clozapine or restarting too high. Both of those can have costly effects. We're avoiding potential admissions, or we are avoiding costly ER outpatient visits. And then looking at the cost of what inpatient testing versus send-out testing is. And every hospital will need to sort of review this on their own. What are you paying to send this out? How much is that costing you? And then additionally, if you're sending it out and it's taking 3 days to come back, what is the cost to the patient, quality of life, hospital, on waiting on making a decision versus being able to make it within 4 or 5 hours? Our biggest hurdle probably was getting with the lab. This took a little bit of door knocking. I know I stood at the lab director's door many times to provide them insight into mental health and the need for clozapine levels. When we were doing this, it was, in that post-COVID era. So there was a lot of still clozapine testing going on, or COVID testing going on, a lot of demand in the ER and in the lab itself. But it did take some pushing, but we were able to talk about the clinical need, some of the cost avoidance that we could have if we had this level the same day. Our lab director asks, well, I don't do very many clozapine levels. There's, nobody sends them out. Why would we even bring it in-house? And we talked a lot about people aren't getting levels because they take so long. And if we brought them in-house, it would increase our volume. And lab was very worried about volume. So increasing our volume that we were doing would increase as we educated people on the ability to have them available. We were able to use the FDA cleared reagents. And I will really say this was really a turnkey clozapine test implementation. The company worked very well with our lab and able to validate and using the same methodology as other diagnostic companies to get our lab up and running. And these run on the same analyzers that your lab already has. It's just purchasing of the reagents and doing some validation testing. And the company works very well to make sure that's all set up and ready to go. And we got up and running. And so our next big feat was getting out in front of the community at the hospital and talking about how are we going to do this? How are we going to tell people that we've made this change? So we started with our prescribers talking about how to interpret results, looking at these results and understanding what they mean. We talked about updating and defining our new workflow. We worked very well on thinking about protocols for when blood levels should be obtained, when in the inpatient unit, when in the outpatient, and then in our ER, because sometimes our ER physicians may be unaware that they can even get a clozapine level if they haven't consulted psychiatry yet. And then how to manage unexpectedly high or low results. And I have a couple of slides towards the end of the deck that talk about how to manage those. In our ER, in our medical teams, typically where we would see the consult psychiatry or pharmacy, we really just had to tell them they can order it. And when they should order it. I'm of the opinion, anyone that comes in, get a level. You don't know when the last time they took their clozapine, but we can at least manage with the level that we have. We needed to make sure that all of our workflows were up to date. So we worked with IT to make sure that our rapid clozapine level became our default level in the EHR. If you wanted to do the send out, it would require you to actually input that into the EHR. That took a little bit of hurdles because we needed to go through IT committees, but it does make it our default order now. For patients and caregivers, it's really communicating why testing is being performed, especially if they haven't had it done before. But we all know with the clozapine REMS and all the monitoring, adding a blood level on is probably pretty simple if you have a patient who's already agreed to come and get those other labs drawn, and really can help their treatment plan in identifying the best effective dose for the patient. So I'd like to think about when to obtain levels, and really when you're starting to think about your protocols and how you're going to manage the potential caseload. This is what we did. So we had a 32-year-old patient with a history of bipolar and schizophrenia. He presents to an outside hospital on April 4th for increased hallucinations. The patient is then transferred to our institution. We are a large academic medical center, so tend to take a lot of transfers in. And this, of course, always happens in the middle of the night, right, where patients are moved. So, about midnight, the patient's transferred to our institution. Our receiving inpatient team confirms a clozapine dose for this particular patient. Patient said, yeah, I think clozapine sounds familiar, right? They're on clozapine. We find out that morning that they're on 100 milligrams in the morning, 300 at bedtime. With this confirmation, which was very lacking of details in the EHR, stated, hey, patient's only missed one dose. So let's just get started on the same home dose. Hasn't been that long, and we get the patient started. So these are some of the symptoms: auditory hallucinations. And again, patient was unsure, but thought clozapine sounded familiar, which makes me a little nervous when they think clozapine sounds familiar, but we were able to confirm and got the patient restarted. So after restarting clozapine with the morning dose, then we decided to draw a clozapine level. We'll come back to that point. We find that our clozapine level is less than 68 nanograms per milliliter. So extremely low, but we've already restarted clozapine. The next day, the patient is somnolent and almost impossible to awaken. And I'm sure at this point, we're all thinking, okay, we've probably given this patient way too much clozapine by just restarting at that high dose, especially because the patient probably got the evening dose as well before we were able to determine that the clozapine dose was so low. So another misstep in understanding that probably the best practice would have been when the patient presented to the ER and said, hey, clozapine sounds familiar. At that point, we should have drawn the clozapine level, probably would have seen that the clozapine level was very low, could have restarted or retitrated the patient instead of just restarting at the home dose, and would have avoided this potential adverse effect from too high of a dose of clozapine. The inpatient team did then retitrate the clozapine instead of just continuing. And 2 weeks later, the patient was at their level of 195 of nanograms per milliliter. So a much better outcome. Obviously, our concern was that the patient was not adherent to the medication proven by these adverse effects, but the possibility to avoid these type of side effects and have a better plan for the patient, just drawing that clozapine level as soon as we determine a patient is on clozapine. So we did have the need to retitrate clozapine. Managing this change, as you can see from our examples, is a top priority in making sure that we're communicating, because we do have the potential to avoid some of these unintended consequences of restarting clozapine at the wrong dose or missing an opportunity to retitrate when it hasn't been started. There are some barriers to using the potential rapid clozapine level. We hear a lot about metabolic ratios with clozapine and norclozapine, and a lot of discussion around the need for that metabolic ratio. Probably best practices would lead us to believe that utility of rapid clozapine level is greater than metabolic ratio. So for myself and many experts in the field, having the clozapine level and the ability to make a decision is going to be vastly more important to me than a metabolic ratio. The metabolic ratio really is looking at how the patient is metabolizing that particular medication. The metabolic ratio shouldn't change over the course of time unless the patient's been put on some other type of inducer or inhibitor. So maybe one time over the course of their life do they really need a metabolic ratio. Using the clozapine level is really going to be vital to making clinical decisions. Our lab was very concerned about our test volume being too low, but as we saw people becoming familiar with the increased utility in quickness, our volume increased. And more providers are ordering levels and ordering them at a more increased frequency. It changed our methodology. So our lab was now running these tests. So there was some education and training, but it worked very smoothly within our laboratory. And I'm happy to talk offline if anyone has concerns about how it might work in your lab or how we approached the lab. So let's think about some best practices for utilizing these levels. And I've given you a couple cases, and we have a few more within the deck, but I want to spend some time thinking about some of the best practices. Now that we have real-time data, we can make clinical decisions in real time versus waiting several days for that result to return. So as we thought about our protocols, thinking about reinitiation. So this can go back to case one, where the patient had a very low level. And how would we retitrate? So if they have an undetectable clozapine level, let's look at the patient. Let's look at the symptomatology. Let's look at a baseline clozapine level if it's available. And as you get started, potentially with the rapid clozapine levels, you may not have baseline leveling on your patients, but this really is a best practice to know what range your patient responds to clozapine in. And then retitrate if needed. And so we know, okay, if our patient typically responds at this level, we can retitrate clozapine. And this is the level that we are looking to get the patient to because they've responded to that in the past. That's probably the easier one. Now, if the patient has an identifiable clozapine level and we're sort of in the middle, let's look at the symptomatology. Let's look at where the patient is. Are they experiencing symptoms? Are they not experiencing any symptoms? Where is their baseline level in comparison to the level we have today? So we may consider a dose increase if it's clinically indicated. If the patient has symptoms, maybe their level is lower than where they normally fall, or even if they are where they normally fall, but they're still having symptoms. We might hold or discontinue the medication if the patient's level is really high, or if the patient is experiencing adverse effects. Maybe the level is high, but the patient's doing well. So now we may increase our monitoring for adverse effects. There are a lot of great resources to think about on how to develop some of these reinitiation protocols, but I would really, really advocate for including that real-time decision-making and levels in those reinitiation protocols within all of them. And then it's easy to get the level if you're retitrating, once the patient reaches 100 milligrams, re-getting the level. And then anytime there's a dose increase or a change in dose, it's very simple to add on that clozapine level. In our discharge planning, we now have the ability to determine the current therapeutic level prior to discharge. To me, this has become essential for future decision-making. Being able to hand somebody on the outpatient clinic a level of where the patient is And maybe we say the patient still got some minor symptomatology, but here's where they are, and you have room to continue to titrate, or the patient's doing well, and this is where they are. We would be able to provide that to an outpatient provider so that they're not guessing. We're also able then to review previous levels and predict what might be occurring in real time with the patient. Ultimately, if we're able to restart clozapine or continue clozapine, we might be able to get patients out quicker. We have the potential to discharge them if we know they're already on clozapine and we don't hold it and retitrate, or we can retitrate sooner because we're not waiting around for a level to return. We're not waiting days, wondering. And most of the time, probably what we did was draw a level, send it out. We made a decision and incorporated it immediately. And then the level comes back 3 or 4 days later. And it's really worthless at this point because we've already made a decision. We weren't waiting 3 or 4 days. So it really improves communication with the next provider, is an asset when we're now sending out our patients. So here's another case that really was important when thinking about levels. So you have a 48-year-old patient, diagnosis of schizoaffective disorder, had a month-long admission to another hospital. At this other hospital, there was concerns of NMS. So all psychiatry medications were discontinued, catatonia developed, as well as psychosis, which is really what led to that month-long admission. The patients then transferred to the university. Clozapine was started and titrated to 300 milligrams nightly. Previously, the patient was on a home dose of 500 milligrams. We get a clozapine level after the patient's on 300 milligrams, and the level is 458 nanograms per milliliter. The patient is still experiencing a little bit of symptoms. So at this point, I would ask the team, okay, if the patient's still experiencing symptoms, what kind of side effects, if any, is the patient experiencing? Do we believe the patient could tolerate more? They were previously on 500. It would be nice if I had baseline leveling. Perhaps this patient runs at a 600 or 650 nanograms per milliliter, and that's where they baselined before, based on the home dose of 500. So there's an opportunity here, if we had a baseline level, to know if we should push this 300 milligram dose higher. So here are some of the symptoms the patient was still experiencing: speech latency, thought blocking, auditory hallucinations. Our inpatient team decided, since the 458 fell near the therapeutic reference range, that they felt that it was an adequate clozapine level, and they considered adding a first generation. And so here it's where it's important to have some baseline leveling to understand perhaps this patient could tolerate an additional dose of clozapine. We may be able to push that higher and continue to monitor for adverse effects before we went to polypharmacy. But unfortunately, without the baseline level, our team was hesitant to push the dose any further. And so here are some real important areas for education around dosing and concentration. And really, if we have the opportunity to have that baseline level, it's really important. So we have a 45-year-old patient with bipolar disorder mixed. After the patient was started on clozapine, there were fewer symptoms present. As we were preparing the patient for discharge, we noted in their discharge summary their current clozapine dose, so 50 milligrams in the morning, 175 at bedtime, and what their current clozapine level was. And for us, this is very important. This is what we want to provide on discharge. We would include the date of this particular clozapine level, and then additionally information about, are there still symptoms that could be addressed? And with fewer symptoms present, yes, there might be symptoms that can still be addressed. The patient's safe for discharge, but this level allows the practitioner who's receiving the patient to know there is room to increase the dose. So a good opportunity here for an outpatient provider to know where they're starting from. So instead of on day one saying, let's get a level and make a decision, they already know where the level is. So using these therapeutic drug monitoring guidelines, we can see different situations where it may be important to get levels. One of the areas that we get sort of entwined with is manufacturers of clozapine. And we all know that even on the same dose, sometimes with the change in manufacturer, we tend to see various things. We can see changes in symptoms, levels may increase or decrease. So having a historical level is really important when you have the potential for a change in manufacturer. And this also allows a quick determination if there is a change in levels. And then we know it may have been a medication versus the patient missed a dose or had some other new factor that played in there. As the patient experiences adverse effects, we have the ability to get a level to allow for future decision making. Will we increase? Will we decrease? And also that baselining when the patient's doing well really helps provide that personalized therapeutic interval for all of the patients. I would be remiss if I didn't come back to provide some insight into variation in levels. Over the course of time, even on the same dose, patients may have about a 30% change in their clozapine levels. So looking at this particular study by Lee and colleagues, you can see the green line here is the upper limit. The orange/yellow line is the lower limit. And the red line here is the mean of the first 3 points. And so this kind of gives you an idea here of various levels that a patient may have been experiencing and really looking at the mean of those levels to sort of make a determination of where that patient might fall. And so when you're looking at baselining for a patient, a single level is probably not enough to make a decision. It's very important to really establish that baseline by looking at the mean of several levels for that particular patient. And this really helps to determine adherence as well over the course of time. And so best practices would suggest for fluctuations greater than 50% around that mean that you might expect non-adherence or changes to other external factors. So a single level isn't always ideal. Sometimes that's all we have, and we'll have to work with that. But it is important to think about over the course of time, a patient may fluctuate up to 30 or lower than 30%, and that might be okay for the patient. And not just using one level as a one point in time. So if we have unexpectedly low levels, we want to make sure it's a true trough. Were the baseline levels that we had before true troughs? So really important to note time of lab draw and time of last medication ingestion. Are there pharmacokinetic changes that might have influenced this? Smoking, other strong inducers, other moderate inducers. So any of the other medications that might be affecting that. Thinking about adherence. Automatically, I think when we think low levels, people think adherence. Always consider adherence. You might consider metabolizer status, especially with these other medications, or is it absorption of the medication? There's a whole host of things that could be going on to weigh in to think about low levels. When we think about the opposite end of the spectrum, the high levels, again, let's look at the time of the lab draw. Let's look at the time of the last medication ingestion. Is it a true trough? I always, if I have an unexpected high level, consider a lab error. The first thing my knee-jerk reaction to do is let's get another level. Let's verify what we see. We could think about other pharmacokinetic changes. Have they stopped smoking? Were they given a strong inhibitor or a moderate inhibitor? Are they taking too much? Is there some sort of infection? The first thing that's highlighted here in red 2 to think about, call the patient. Let's find out how they're doing. So if you get a really high level, it's a true high level that was really unexpected. Let's call the patient. Let's ask them what's going on. Let's see how they're doing. Let's see if they're experiencing side effects, and really try to determine what may have happened. Maybe they say they took extra dose, or they forgot to take it last night, so they doubled up this morning. Let's really try to figure out what's happening with the patient. So not just using one item of information to make a decision. Our last sort of thought here on this particular patient 5, maybe when our plasma level doesn't equal what we're thinking. So if we have a patient who's receiving clozapine, this is a patient with schizophrenia, presents to the ER, they're taking clozapine 500 milligrams daily. They report they last took their dose in the morning, but they're still experiencing some symptoms of agitation, aggression, paranoia. Let's get a level. Let's see where the patient is. But what are you going to do with that level if it's a little bit different than maybe their last level? So what changes in serum levels are going to sort of get under your skin, I guess, a little bit? If you went from 209 to 328, is that going to affect what you might do? Is that enough of a difference? Is it 391 versus 467? Is that enough of a difference? What if somebody drops from 428 to 323? Is that enough of a difference? Now, this last example is really where it crosses that 1,000 nanograms per milliliter magical line. And this is when many of the labs will alert you, is when it's greater than 1,000 as a very high level. So what if you went from 1223 to 969? Is that concerning? And now, before, they might have ranged here, but now they're less than 1,000. Patient in the ER has a level of 1,100, which is pretty high. I don't know his baseline level, so I don't know if this is normal for this particular patient to run this high. If the lab come back and reports a level of greater than 1,500, then what am I going to do? So these are all certain things that you'll have to have discussions with your team. Where is our level of concern? In many of these situations, I'm going to be reevaluating anything that comes back high and it's unexpectedly high. So in our particular patient, I wouldn't have expected a level this high in this particular patient. I would redraw the level. Let's make sure that there wasn't any concern with how the level was drawn, how it was transported, any lab errors that may have occurred unexpectedly. And if it is truly that high, let's look at the patient, see what is he experiencing. Are there side effects? Is it an additional psychosis? What kind of things are happening? Let's do some medication history. Let's look for those inhibitors of metabolism. Let's look for signs of infection. Let's rule out all of the other causes while we're doing this. It's a lot of things to really unpack with where you're going to draw your line about when you will act and when you won't act. Clinical blood level information is so relevant and is very relevant in the time frame. We do know that objective medication data results in better dosing, better titrations, and this is evidenced by many of the cases that we talked about today. We allow for better quality transitions of care with this information. Our patients now leave our hospital with objective data in hand about where they stand. So it's really become routine clinical practice with using the rapid blood levels in-house. And we do this both for our inpatients and our outpatients to allow for better continuity of care within our system. Keep in mind, we know that there are lots of other factors that really can hinder or cause some barriers to clozapine access with the REMS. Please keep in mind in November, there's a psychopharmacology review panel meeting to discuss the REMS. So hopefully we'll be able to continue to increase access to clozapine for our patients. So as we dive into discussion and conclusion and questions, if you have questions, now would be a great time to sort of drop those in the question and answer box. Thinking about the use of blood levels and how essential they are to clozapine. is vital for psychiatric pharmacy. We have to be the biggest advocates for this. Our same-day levels can enable quicker decisions, real-time evaluation of patients. Looking across the board, the smattering of patients that we had today in this presentation really allowed for some real-time examples of where, if we would have had levels, it just probably would have made patient care much better, much easier, and resulted in better outcomes. Our turnkey implementation at our hospital was amazing. It was very easy for the company to come in, work with our laboratory to be able to provide the reagents, get them all set up, validated, and we were able to hit the ground running because we had done our homework and getting IT all set so that everyone was ready. As the psychiatric pharmacist within our team, we hope that we're all able to order and interpret results. Ordering may be different based on the practice setting and scope of practice that you're in, but our team assists in all the interpretation of results. And we can do this across multiple facilities within the university system. So we may get calls from other hospitals to ask, what do you think? How would you interpret this? What do you think about this particular patient? It really allows for some interprofessional care. We've been able to educate healthcare providers and get out in front of the team and really talking about best practices with clozapine and provide better patient care across the board for our patients that are receiving clozapine. We're hopeful as time continues to move on that we will increase our clozapine utilization within the state hospital systems here in Maryland. We are working on some potential research and projects in the future to really think about incorporating additional psychiatric pharmacists to help with some clozapine interpretation. But I think this is a great place for us to share expertise in this area. So I'd love to welcome any questions, comments, thoughts that you guys have as a team here on the call. If there are things that you'd be interested in learning more about.
Thank you very much, Dr. Ehret. That was a fantastic presentation. I feel like I've seen you do some version of this many times, and every time I learn something new. So very much appreciated. As of right now, we don't have any questions, but we can give them a few minutes.
And also note, please, if you have questions after this, you go home, you think about something, you want to do this, please reach out. I don't want to say Vinny or I, but we've been working a lot on these levels. I'm very hopeful that our state hospital system will get them soon. We're working on trying to implement this more statewide within Maryland, but we will take blood levels from other places. So if you are looking to implement this, but maybe your lab isn't open to the idea of running them themselves, please reach out to Saladex as well. They are helpful in locating other places that might have it, and you might be able to send your patients or your blood to a different hospital nearby to get them.
So we do have one question. Can you comment on cost differentials?
I knew this. I probably should have done my little homework on this. I will say I am uncertain of what our hospital pays for the reagents. I don't know if that's proprietary type of information to understand the differences in what we pay for it. And I'm not 100% certain what our send out is, but I believe at the end of the day, it is very comparable in cost for that type of service. At the end of the day, in my mind, even if something costs a little bit more, to me, it would be worth it if I could have better patient care. And I know that's maybe not the answer the lab or the hospital wants because they're going to want dollars and cents. But we have to think about the greater healthcare picture. Are we saving an ER visit? Are we saving maybe a hospital inpatient admission day or a second outpatient visit or provider time? If we have the lab on the same day, we're able to make decisions that day versus having to set up time for my provider to call back the patient tomorrow, which then eats into appointment time for tomorrow. So it's kind of hard to judge these because it's really apples and oranges in comparison to just comparing the cost of an LCMS versus the cost of the immunoassay.
I think reducing that length of stay is a really
Yeah.
good marker, right?
It,
Especially in the inpatient, the acute inpatient, where they're not, at the state hospital for a long period of time. And there's other factors that are maybe preventing them from leaving the acute inpatient units. If you can
oh,
find out that day,
yep.
huge.
I look back at our first patient and I thought, darn, if we would have caught this, I thought, well, this person had a spot in the PHP, which meant that someone else didn't get into the PHP. And then this person didn't come. So that spot really went empty for 2 days. Well, the patient likely suffered symptoms in the community and then got admitted. And so if we could have admitted him 2 days sooner, the downward effect. One, he's getting better treatment, better quality of care because he's getting treated now, and perhaps that PHP bed opens up, and now someone else could take that bed. Just a couple different ways to look at it, and I know it's very hard sometimes to sell because we work in a very siloed healthcare system where everyone cares about their own costs and maybe not everyone else's costs.
Comes down to hard dollars versus soft dollars.
Well, I don't want to take the last 3 minutes, but please note if you have questions afterwards, please reach out. If there's anything that I can help with to help you establish these programs. I want to thank everybody for the opportunity to gather here today. And thank you to Saladex for supporting this time and AAPP for promoting.